This is the second of two cases planning the Contura balloon applicator with Oncentra brachy. This is a more difficult case than the first case where we had no concerns about skin or chest wall distances. As you can see, in this case, we're close to both the skin and the chest wall. Exactly how close we'll go through in just a minute. There are a number of features of this case that are different from the other case, and I'll try to point those out first, and then we'll get started. Now, since we've already been through the definition of the structures and so forth, we will spend very little time on that. You can see, if you look below here, that I've already created most of the structures that we'll use for planning. Some of these I did not have for the first case, and I'll explain why that is in a minute. Keep in mind, of course, that the definition of these structures is a medical decision and is at the discretion of the radiation oncologist. So what you see illustrated here is for example only. Your mileage may vary, of course. It should always be done in conjunction with the radiation oncologist. What we're doing here is for process, not for the details themselves. Now, if we look at the features of this particular case, you can see immediately that we're right on the chest wall and that we have a relatively small distance to the skin. If I bring up the applicator here, you can see that it's impinging directly on the intercostal muscles here. Of interest in this case is that the ribs themselves are quite far apart and not well ossified in this area, so they don't show very well. You can see that there's a rib here, and there's maybe something here, but it's not ossified, and we did not identify that as a rib. If we bring the ribs up, we can see that at various levels, if I scroll up and down here, you can see it gets a little bit close in some areas, but there's a large gap in here that is special to this case, and that will bear on the optimization later on. You can also notice that the skin distance here is relatively small. As it turns out, the skin distance and the minimum rib distance are both about 5 millimeters. Now, I've illustrated that by placing a 5 millimeter margin on the balloon here. I'll turn that on here. See it? And if we move up and down, you can see that that at some point we'll be just touching that right here with the rib. Below that we're farther away, and above it we're farther away. But just 5 millimeters here and 5 millimeters here to the skin. So this is a relatively challenging case, and we're balancing off both rib dose and skin dose. I won't say anything further about that distance now. I'll turn that off for clarity. Also of interest in this case is the air pockets that are here. You can see in the central slice here that it looks like there's an air fluid level inside the balloon, meaning that this region here is probably all inside the balloon, but it's contiguous with an area of air outside the balloon. Now, that's not too much of a problem for us, as we know that we can make pretty much a circular reconstruction of the balloon here in two different views and get a good sphere, and we have a good idea where that boundary is. And then if we contour all this area and subtract out the balloon, what we'll be left with is the part that's just outside the balloon, which does in fact constitute nonconformity. Just to convince ourselves that this is really true here, what we can do is, in this particular case, is we can change the window and level settings to widen them a bit and see if we can visualize that balloon surface. So I will just take the window width here and I'll gradually widen it. And as you see, when we get there, that you can actually see the balloon surface here. So we know for sure that that's really what's happening, is that we have some air inside the balloon, some air outside the balloon. Whether this air outside the balloon is a significant nonconformity is the real question for this case. So I've contoured that region, and then I subtracted the balloon out from it, and it's listed here as air. And there's another feature that is of interest here as well, and you can see that this air volume that I've contoured doesn't look like it fills that entire volume. And that's an illustration that even with an air bubble, you can have the same kind of artifact that I mentioned in the early case for a high-density object or a low-density object. And this is called a blooming artifact. And the fact is that because of partial volume effects, this area in here is represented incorrectly if we have our window and level setting set too narrow. And you can illustrate that, again, just by widening the window. As we do that, that air volume appears to shrink. It doesn't really shrink, and it's just the way that it's represented when you do windowing and leveling. Now, I used the paintbrush tool of the magic wand tool in here to capture this. Of course, it got all of the air in the balloon as well. Subtract that out. The magic wand tool gets it correct because it goes back to the original Hounsfield values, so it will get it correct. So this is what the real size of that is, but it's easy to get fooled when you have window and level settings that are designed to allow you to see the breast parenchyma well, that you may not see the edges of these high contrast structures in exactly the right place. But just bear that in mind. Whenever you create structures of high density objects, you need to widen the window and make sure that they still make sense. Now, another issue that I'd like to illustrate with this case that we didn't with the last one is that if you evaluate the V150 and the V200 based on the PTV eval, you may miss some of the high dose that's in breast tissue that is excluded from those. And that doesn't happen in a case where you're a long way from the skin, but in a case like this where we are close to the skin, in this case 5 millimeters, and we place a 5 millimeter margin to the skin for our PTV eval and our PTV op, let me turn both of those on, you can see that there's some breast tissue in here that's very close to the balloon, but it's not inside either of these structures. So if we do a DVH, looking for the high dose volumes within breast tissue for that particular item, there may be some high dose in this region that is real in terms of producing potential for fat necrosis, but would not be accounted for if we evaluate the V150 or the V200 on the PTV eval itself. So for that reason, we're going to illustrate a way to capture that that's different from what they show in the B39 protocol. In B39, those of you who've done that know that you're supposed to evaluate over all the breast tissue. Well, where the breast tissue ends is not really easy to determine, and it's a rather tedious structure to try to define, and they do it in a kind of simplified fashion. But what we really want to know is what breast tissue is at high risk to have high doses, and we want to limit that evaluation to only the breast tissue. So one of the things that we can do, and I've done it here, I won't go through the steps, but I'll show you the result. What I've done instead is I've started with the applicator, and then I place a margin on that just as I did for the PPV, but this case I gave myself a larger margin of about 2 centimeters, and instead of limiting it to the chest, to the skin with a 5 millimeter margin, I limit it with 0 margin. I still also limit it to the chest wall. So let me put the chest wall up here so you can visualize that, and then I'll put this V150 structure on. This is what we made for evaluation of the V150 and the V200, this region in black here. Note also that we have to subtract the balloon from that because there's high doses within the balloon. We don't want to account for those in our V150 200 calculation. So you can see in this illustration and in these other views, we have done that correctly all the way out to the skin, about a 2 centimeter margin. That's really not very critical. You can evaluate like that the same way we did with the other one. If the 150% isodose line does not fall outside that, you've got plenty of coverage. Likewise, if the 150% isodose line doesn't go outside your PTV eval, then the doses you find here will be the same as a PTV eval because we're looking only at absolute tissue volumes rather than percentages. So we have an additional structure here just for completeness, just to make sure that we get the V150 and the V200 exactly correct. Okay, let's go on to the actual planning steps. In the newer versions of Oncentra, which you may or may not have, there's a new tool right here that allows you to bring up different workspaces that you have configured. What I have here is my reconstruction workspace with ECS views that I've used to reconstruct the channels themselves. But I also created a separate one for IPSA, and it looks like this. I have just 2 views of for isodose distributions, a large view here for the DVH, which is going to be very important. And in this case, we have IPSA the IPSA window down here and the Case Explorer here. Let me do a little bit more setup on that just to make everything a little easier to see here. Okay, here's the setup for the optimization and evaluation workspace, and let me go through each of the sections one by one. If you have a relatively low resolution monitor, you may have to move your cursor to one side or to the other. If you move it to the edge, your screen will scroll to show you the rest of the screen. I'm using a rather high resolution screen, which makes it very handy for IPSA. Okay, so up here we're using this for isodose distribution evaluation, and you can see this is an actual CT slice. It's number 67, and it shows our PT val here and here, and it shows the nearest rib in this particular slice, which is not the nearest anywhere, which is right here. The slice below it is sort of a quasi sagittal view. Let me bring it up so you can see where it goes. It runs through this direction, so it shows us again the PTV eval and the nearest rib, which is here, and also goes through two of our channels so that we can visualize those fairly well. The other thing that I generally like to do when I'm doing the optimization is that once I get the structures on that I want here, I don't have to click on that anymore. I can come back down to the applicator and I can show the dwell positions themselves. You can see in this particular case that we did our reconstruction properly. We have an offset for each one of these of -4 millimeters because I reconstructed from the very end of the channel. We measured the indexer length, well, I just faked it here. Also, in this particular case, since the channels have been rotated to maximize our capability of reducing the skin dose, each of these channels has a particular significance. So channel number 1, which is right here, which is aimed toward the skin, you can see it right here. It has this light nitinol marker underneath the channel. I've given it a name. I call it the skin. And number 2, which has a CT marker in it, which is kind of lateral here. This applicator is in kind of oblique, so it's lateral inferior, and that's shown here. In this case, I've given it the name lateral. Channel number 3, which is here and here, I've called chest wall. The other one is medial, and of course we have the one in the center, which is, I just called it central. But I set this up so that I can visualize these dwell positions as they're activated by IPSA so that we make sure we know what's going on there. We have also our DVH window here, and what I've done here is that I've requested DVHs for the structures that we are interested in here. They're not necessarily the same as the structures we show here. So we have here the skin max structure, which of course lies outside the skin here. We have the V150, which is that big black structure which is around here and comes right up to the skin. And we use that for evaluating the V150 and V200, remember. We have the PTV eval, which is for coverage. And we have the rib structure, which is also shown here, that will show us what the maximum dose is for the ribs. And I've also requested a DVH table, and I've got that all set up here. On the PTV eval, we're evaluating the V95 so that it's indexed to the 95% dose here, and it will show us the percent volume here when we actually do that calculation. For the ribs and the skin max, what we're doing is, again, we're taking a 0.1 cc volume and considering that the significant dose. And, of course, for the ribs, the actual maximum dose will be higher than that, but this is one standard way of evaluating the high dose to a structure is to take a small finite volume so that you get good statistics on it, and that's what we've done there. V150 and V200 now, instead of being evaluated on the PTV eval, are evaluated on the V150 structure instead. So this is a little bit more correct, although the results should not, in the end, turn out to be much different. If we look also then at our IPSA objectives, we put the applicator in as a target structure, and you see there's no objectives for it. We have the PTV for optimization as before. That's our reference target, and we have to have a surface dose on that. The minimum surface dose to the reference structure is always the prescription dose. So our prescription dose is listed here with a weight of 100. maximum is 10% higher with a weight of 100, which we may have to change. In the volume of that, we have a minimum of 340 and a minimum of a maximum of 150%, and we expect to change this weight as well. In this particular case, we've also put in the skin max as an objective, and what we'll look at there is what's the maximum surface dose there. And since we want to limit that if we can to 100%, I've placed out a little bit lower than that, which 300 centigrade, so that we get it violated in all cases. So that'll give us a little bit of leverage in our optimization. And we've set that to a relatively low weight, but we will think about changing that if necessary. So let's go ahead and start the optimization and see what we get from this. The optimization is running. It's just about done here. Once that finishes, of course, it'll have to calculate the isodose distribution and the DVHs. And what we want here for the volume is the relative volume and relative dose here. And we'll see a fairly typical result here. We only have 78% to our V95, so we need to have better coverage. One thing to check when we do this is to make sure that the applicator has actually been treated as a target. Sometimes IPSA will get that wrong. We can check that just by looking at the treatment printout and see if it's listed in the objectives. Sometimes when you store this, it won't come back. Oh yeah, it is there, so we're okay. The applicator is listed as a target with no objectives, so that's not our issue here. But if we look at the DVH table, we can tell a little bit about the first pass optimization here. We haven't got enough coverage. That means we can allow more inhomogeneity, so the maximum value for the surface and the volume of our PTB can be, the weights can be reduced on those. The blue background here in all cases means that we have a very low dose. So for the ribs and the skin max here, because we're under-treating this anyhow, those are relatively low now. They're not of interest yet. And the V150 and the V200 are quite small. Remember, the maximum for the V150, V39, is 50 cc's. We try to get that below 30 cc's, and as you see here, we have it very low at about 11. V200, V39 wants to have that below 10. We also want to have that below 10. We prefer it below 5 if we can get it, and it's also very low. But that just means that we haven't got enough treatment here, and you can tell by looking at the isodose lines as well that we haven't covered our volume very well. So the next step is to take the weights of these maximum dose objectives and reduce them and allow more dose there. So I'm going to take the surface dose here. I'll reduce that to 40. Let's reduce it to 20 even. And I'll reduce this one as well, make it about 20. And then we'll rerun the optimization and see how we get. It doesn't take very long to do this. And remember, we make large steps in the first few passes, and then we'll make smaller steps later. Now you see the skin max is right up in the region that we are willing to tolerate at about 102% of our prescription dose. We haven't quite got to where we want to be here in terms of coverage. We have 94% for the V95. That isn't too bad, but we would like to have that over 95%. But that means that we're very close to where we need to be. We just need to make very small steps from this point. Likewise, the V150 and the V200 are still relatively small. They're not a big concern. If we look at the activation pattern over here, we can see that the skin catheter is hardly getting any activation at all. Just at the proximal end here, we're getting a few. And the rest of them are sort of uniformly activated, although we can't tell from this what the actual dwell times are there. They may be fairly small, and I'm not going to go through that yet. Get a little closer. But we know that we need to get just a little bit more coverage here, so what we can do is we can reduce one of these a little farther. Let's take this one down to 10, say, and optimize it again. We could also reduce this a little bit, except that we're quite close on the skin max now, so we don't want to go too far. Well, it looks like we're done. By moving this down to 10, in just a few steps, we've got our coverage right about where we want to have it. 95, the V95 is 95% or a little bit more. So we're in the green here. The ribs in this case, remember this is a 5 millimeter minimum distance, is about 101%. The skin max is about 102%. And our hotspot volumes are quite reasonable. We have 20 cc's to V150, and we have less than 5 cc's to V200. So this is an almost ideal result right out of the box. We made about 3 steps to get here, and that's fairly typical. If we were to look now at where the hotspots are for the ribs, let me scroll to where this is about there. Here we go. Now you can see that with the definition that we've used, the actual maximum dose to any part of the rib at all is close to 150% here. And if we look in the statistics table from the DVH, it'll probably show that as well, but that's really not very reliable. It's more reliable to take 0.1 cc, and that's actually a volume of about 4.5 millimeters, a 4.5 millimeter sphere. So you have to be sure that your radiation oncologist is comfortable with this definition, because it will give you a little bit more dose to the rib than if you would evaluate it looking at the isodoses. But this is a fairly common way. This is the way that the JEC Estro does the same thing for, say, the rectum in GYN cancer. So that is one of the caveats here. The other caveat, of course, is that there may be other rib in here that is not well visualized because it's not ossified, and so the radiation oncologist also has to be comfortable that you're not over-treating the chest wall in that area as well. If we look now at the printout and see what the actual dwell times look like, we can see that that for this skin catheter, the total dwell time is only 4 seconds, very little. The part that's lateral here is getting the bulk of it at 115 seconds. The chest wall is getting an intermediate value. The medial one here is getting less than the lateral one, for reasons I'll explain in just a second. And the center one gets a little bit, not a whole bunch. Now the reason that we're getting more dwell times in this direction here than we are down here, and you can see, if you look at the isodose distribution, this portion is a little bit better covered than this portion is. And the reason is that the optimization is based upon the volumes. And the volume of this side is quite a bit larger than the volume on this side, so it gets more weight in the optimization because there's more optimization points that get generated in that. If you're not comfortable with that, then you have to make other arrangements and try to bring this up, but of course there'll always be a price to pay for that. But this is an optimization based on the volume, and so those parts that have more volume are going to get a little bit more weight in the optimization. That probably is proper unless the small volume side of it, which can sometimes happen, if your close margin area is in this region, then you may want to change the weights of your optimization parameters or do a little bit of graphical optimization in there to account for that. But typically, just going with the volumes themselves will give you a very, very good result in a very short time.